Welcome back to the podcast, Period Party Family. This week, I am talking to the most amazing human, Dr. Mathew Leonardi. He's an advanced gynecological surgeon and sonologist, aka ultrasound specialist, and he's an expert in endometriosis excision surgery and gynecological ultrasound. His focus is on using ultrasound in the diagnosis and surgical management of endometriosis. If you have any knowledge of endometriosis diagnosis and care, you might imagine that this is a controversial topic because the claim is that endo can only be definitively diagnosed via laparoscopic surgery. Needless to say, Dr. Leonardi has taken a lot of heat for his stance on this topic. Anyway, he is an absolute wealth of knowledge on all things endo, and I truly can't wait for you to hear what he has to say. Enjoy this episode. Hey, Mathew, thank you so much for being here with me.
Hi, Nicole. It's so great to be here. I'm really excited for this conversation.
Same. I was looking at your bio and it's very impressive, by the way. I mean, it's incredible. I would love to know, how did you get interested in endometriosis research and patient care?
The story is a long one, but I'll try and be concise.
Okay.
As a trainee in Toronto, at the University of Toronto, when I was learning to become an OBGYN, I really fell in love with the ultrasound tool. I thought that it was an incredibly fun tool to use, so useful in patient care, very dynamic, where you have the opportunity to hold the probe with the patient there, talking to them in real time. And that led me to explore experiences outside of Canada, where there is a better integration of ultrasound into gynecology practices. So I went to London for some time in my training, and then I went to Australia for actually quite a long part of my training, where I realized ultrasound was so useful for diagnosing gynecologic problems. And the one that faces the biggest enigma is endometriosis.
Mm.
So I realized there are things that they're doing outside of Canada that we can be doing better in Canada. And I picked up these very interesting skills that are at the interface of endometriosis and ultrasound diagnosis. And so I really took it upon myself to leave my comfort zone to go outside of the space that is quite typical for a Canadian OBGYN. And that's what brought me to the world of endometriosis, is really figuring out how to enhance that diagnosis with the ultrasound.
Okay, we're going to get into the ultrasound part of things because I can't wait to talk about that. But I just have to say, I am so grateful for people like you, OBGYNs, who are just thinking outside of the box and not just subscribing to the dogma and the narrative that is just the going narrative. It's just so frustrating, as you know. I mean, I feel like I was having this conversation the other day about just women's health in general and working in women's health with other friends who are also in this space, and how it's become almost traumatizing for us because of the daily, mostly horrifying stories that we hear about how badly women are treated and how much unnecessary suffering is endured. And so I feel like this is particularly true for those who have endo or suspect they have it. And it just feels so, it's never felt worse to me in the years that I've been doing this. It just seems like it's getting worse. I know things are improving, but it also does feel like the stories are crazier and crazier. Tell me I'm not alone. I assume everybody has these feelings.
You're definitely not alone. I mean, the reality is, as a person, I'm a very curious person, and that put me in a position to start to ask why we're doing things the way we're doing things, right? That's why I left Canada. I was wanting to challenge the common narrative.
Yeah.
And I think as a researcher, that comes into play as well. We have existed as we are for a long time, but that doesn't mean we have to continue existing like that. We have to ask ourselves, as a medical community, as a society, why? What is missing? What more can we do? What can we answer that will bring us forward? And so that's me as a person. I'm that curious person who wants to push things forward and make those waves to make change, because we are where we are, and there's lots of good things where we are, and there's lots of bad things where we are, but we can always be better. That principle is, in my blood. We can always be better. And that's, I think, where we can go with endometriosis care. And truthfully, in the world of gynecology in general, there are so many things that we don't know, so many gaps, so many deficits in care, and we can get better. We just have to ask the questions how and why, and do the studies and work together as an international community to actually achieve something better.
Yeah. Yeah. And do you feel like that's happening? Do you feel like the shifts are there?
For endometriosis, 100%. It almost feels revolutionary at the moment. There are communities around the world, whether they are patient advocacy communities or gynecology researchers, and even to some degree, politicians are starting to become involved with the concept of endometriosis, pushing that forward. In my time in Australia, I got to be a small part of the National Action Plan for Endometriosis. And I'm still working very closely with a lot of the individuals who are part of this group. This is a group that involves patients, researchers, physicians, politicians, and the needle is moving. Now that I'm back in Canada, I'm one of the advocates for the Endometriosis Network Canada and Endo Act Canada. And I've had meetings with members of parliament. I've had meetings with various people of government level, and they're starting to listen. So things are changing, things are moving forward. And I think the one really important thing to say is the people who are experiencing the problem, the disease of endometriosis, they want things to change right this moment. I mean, they wanted things to change last year or 2 years ago. The reality is that change takes time. That applies to any area of the world, right? Mm-hmm. And it will get there. It's just not there at this moment. So at the same time, while I encourage optimism, also encourage kind of patience and allowing that change to happen. But at the same time, also be loud, right? Continue to push, continue to advocate.
Oh, yes, I know. I agree. I feel like I've seen a massive shift, and particularly in the last 2 to 3 years with, like you said, the patient advocacy and just women speaking out and just saying enough is enough kind of thing. So I feel like things have really moved in the right direction. It seems like a very grassroots type of movement.
Yeah, and that's a nice thing to see. At the same time, I think it's a little bit sad that patients have had to be the force to make that change, because it should really be the medical professionals that are noticing the gaps and the deficits and trying to push forward. And there are a lot of obstacles that the world of OBGYN faces, where there is unfortunate prioritization of obstetrical care to gynecologic care in general. I would say that's quite common around the world. I have now experience in a few different regions where it really does feel like gynecology is the kind of baby sibling to the obstetrics. And so really there's not as much advocacy, clinical care, research focus on gynecology, because obstetrics takes a lot of the attention or the limelight. So patients have had to be that change for themselves, and that's both good and bad, but we are seeing the effect of it, and the effect is a good effect.
Yeah, no, I completely agree. I mean, I feel like I was that 20 years ago when I was seeing doctors and nobody had any answers, and just went out on my own. I went rogue and decided to figure it out for myself. And I think that that's just generally, unfortunately, the nature of where we're at with medicine. So yeah. And speaking of which, you posted something the other day about endometriosis being a chronic whole body inflammatory disease. Mm-hmm. And I think, again, there's just so much misunderstanding about what endometriosis is. I mean, I can't believe how many people I still hear say, well, it's uterine tissue that's now growing outside of your uterus. And I know that that's a very outdated way of describing it. So can we just talk a little bit about what endo actually is?
Yeah, for sure. Look, it's a very controversial sphere.
Yes.
The entity of endometriosis and all of the sort of attachments, the treatments, the diagnosis, it's all very controversial. And I guess my disclosure up front is when it comes to a disease, when it comes to the set of problems that come along with it, it's very difficult to generalize and make bold and kind of black and white statements. I am a huge believer in nuanced, patient-centered care. And every person that walks into my office is different, with a different story, with different goals and objectives. So some of the things we're going to talk about are going to be maybe a little bit more broad-based, not applicable in a specific setting or a person. And so that I just want people to keep in mind as they listen to this, okay? to get to your question around the definition of endometriosis, that's evolving. You're starting to see publications that are coming out now, which are no longer describing it as a gynecologic condition, but as a systemic condition. This is a full body condition. And this is the reality. We know that endometriosis affects multiple body systems. It is a disease that affects, of course, the gynecologic organs. It affects the gastrointestinal organs, the urinary system. It affects the muscular system. It affects the nervous system. It affects the lungs in some cases. So, and of course, there have been publications demonstrating that endometriosis has been found in every organ system in the body. So it is a chronic disease. It is a systemic disease, and it's much bigger than what a lot of people used to think. It's great that we're starting to see the publications describe it as that, but we're just starting to see that. So in medicine, when people start to introduce new ideas, new concepts, it really does take the medical community and society in general an unfortunate long time to catch up. There will always be that catch up, right? Because there's always change and there will always be that catch up. So we're starting to see that now, but everyday general OBGYNs, everyday general practitioners or family docs or midwives or nurse practitioners, it's not going to kind of whittle down to them today. We can try. We can, of course, try more and more, be loud, advocate, but it'll take some time.
Oh, yeah, I mean, no doubt. And so when we're talking about this condition, is it predominantly affecting the gynecologic organs, or are you seeing it more affecting more organs in the body now?
It still really is overall a pelvic condition. Right. It really is a disease, if you think about it from a lesion-based standpoint, where the disease exists, the physical disease that we could see with our eyes. It is really primarily in the pelvis, though there are, of course, many people who have the disease outside of the pelvis, and many people who have experiences that are not quite pelvic experiences. This is the sort of symptoms of fatigue or bloating or sort of upper gastrointestinal symptoms. But it really is more than anything a pelvic disease. It starts that way. It starts as a pelvic disease in most people, and it becomes a bigger beast with time. There is the entity of chronic pelvic pain. And whilst most people don't quite consider this to be a diagnosis, it is an experience that endometriosis, unfortunately, leads to in a vast majority of people. So it starts to cause other things to happen. There's the entity of endometriosis, pure endometriosis, and in its earliest days is going to be primarily cyclical, period-related issues. Cyclical pain, cyclical bowel symptoms, and over time, the way that the endometriosis and the inflammation from the endometriosis transforms the pelvis and transforms the muscles and the nervous system, it becomes a bigger entity. So the treatments thereafter are much more complicated. It's not just a matter of all you need to do is take out the disease. When it becomes that bigger beast, it's much more complex. So I think that's really important for people to understand the evolution of it, since it's not simple at all. It's one of the most complex diseases. It's so enigmatic in so many different ways, and how it starts, how it develops. There's so many things we don't know, but we're at this revolutionary time where I think we're going to start to see these answers.
And so can we talk a little bit about that? What in your opinion are we, or I'll say this again. So in your opinion, what are we looking at in terms of like causes? Do you have a better idea of what's causing endo? Is that like a 15-minute answer?
That's a tough one. Look, so there are only theories at this point. Okay. I would not say that anybody has come up with this revolutionary, we have found the gene for endometriosis, we have found the protein that leads to endometriosis. There are a number of factors that go into it. There are theories that claim endometriosis is deposited essentially in utero, which means as a fetus that is XX in genetics is developing, there is deposited tissue, and that may stay dormant for a number of years and then essentially surface around the time of puberty, when the reproductive hormones of estrogen primarily start to develop. There are theories that there are changes in the lining of the pelvic tissue called the peritoneum that are exposed to various issues like inflammatory markers, the presence of nearby cells, and that tissue can change into endometriosis, even though it's not endometriosis or endometrium in its earliest days. There's this transition that's called coelemic metaplasia. There are still, of course, theories that there is retrograde menstruation, and this is definitely the most controversial theory that is in existence right now. This statement you made earlier, endometriosis is not the endometrium, kind of stems from this question of the validity of the retrograde menstruation theory. For sure, none of these theories are going to be a standalone problem. So even if retrograde menstruation is a cause, it's not a cause on its own. There's going to be other events happening in a person that is going to allow the concept of retrograde menstruation to develop into endometriosis. It's not just you menstruate backwards through your fallopian tubes into your pelvis and then bam, that becomes endometriosis.
Right.
There are stem cell theories. There are microbiome theories. So there are so many theories that exist, and we don't exactly have the recipe.
Right.
A lot of that comes back to the concept of diagnosis. People have a very delayed diagnosis. So you can't really understand the earliest days of the disease when you're working with individuals who have it, because when they present or when they're diagnosed finally, it's many years after the disease actually would have started.
Right.
So there are individuals in the world that are working with adolescent populations, and this is really going to be, I think, one of the most valuable research domains, because this is when the disease is going to start in terms of its, at least its presentation of symptoms.
Right. That's so helpful to know. And it's interesting to me how many people still believe that endo starts later on and that it's, not really possible for adolescents to have it. So I think that that's something that really needs to be debunked. But I'm so curious about what exactly is causing all of these things to happen. Like, what's causing this to happen in utero and the stem cell side of things? And, what is it? Is it our environment? Is it what's happening on our planet right now? I mean, we have unprecedented levels of psychological, mental, emotional stress. We have unprecedented levels of heavy metals in our air and in our water. I mean, I could go on. Do you think that there's that some component of that is true too, potentially?
For sure. Maybe the cop-out answer, the easy answer is everything is multifactorial, meaning there are lots of contributors to something. And so one of the very interesting theories was proposed by a really prominent Chinese gynecologist, Sunwei Guo, in an article in Human Reproduction a few years ago, that people who menstruate now are menstruating more than 50 years ago. So you think about the number of pregnancies a person has in their life now. It's region dependent, of course. There are still places in the world where they're pregnant a lot, but in sort of North America, in Canada, in the US, in the UK, in the Western kind of world, we're having way less pregnancies. So you're menstruating more. And so is this something that's causing tissue damage and repair cycle more? Every time the uterus menstruates, there is a tissue damage that happens. It's an inflammatory event. And then the uterus has to recover. And the uterus is an incredible, incredible organ. It's one of the only organs that does that on a regular basis in such a cyclical fashion. So this concept of more menstruation leading to maybe more issues around endometriosis and adenomyosis is important. There are people doing research on things like nanoplastics and the content of our food and our water and our air, and how could that be changing the gynecologic organs or the other organs that are in our body. So multifactorial for sure is going to be, the way that this disease exists. I think it's also kind of relevant to think societally in some ways, because we're at a place now, again, at least in sort of the North American context, where women have an ability to have a voice much more than 100 years ago, right? So did those people who existed back then have the same problems as today's women, and they just didn't have an opportunity to say something about it? Yeah, I think we have to start asking, is the disease the same as it was then? Or are we just hearing more about it now?
I'm so glad you said that, because I was thinking that too. Is the prevalence increasing, or is this something that has always been there? And
For
even,
sure.
I mean, potentially dormant based on the environmental triggers as well.
Yeah. And this is probably, with the exception of maybe some diseases like diabetes, which seem to be very dependent on region and intake foods and drinks and stuff like that. With the exception of some diseases like that, we're probably seeing the same things that we were seeing 100 years ago, just seeing them in a different light or not recognizing that they existed at that point.
Right. No, it makes complete sense. I would love to get into the diagnosis process. We all know it takes literal years, sometimes decades, sometimes those who have endo don't even get a diagnosis. I've had women reach out to me in their 70s and say, this is definitely what I had. And of course, no one knew how to diagnose. And what is going on with the diagnosis process?
So this is my main area of interest, I would say. So I could do, a podcast series on this. So again, I'll try to be.
I'll have you back.
Super concise, okay? So the first thing I think to say is that the concept of pain and women's pain in general has probably been unacknowledged for a long time, invalidated, not believed. We have medical tests, right? So we have tests such as ultrasound and MRI. And when a test is done and nothing is identified, that often is the point of invalidation of a person, where a medical professional will say to somebody, we've looked at your pelvis and it's normal, and so therefore you're normal, therefore you don't have a problem. And the patient sits there and says, well, I do have a problem. I'm telling you that I have a problem. So there's this discordance between what the capacity of a test can do and the experience of the patient. And there is really, truly a lack at this point, at least. This is something I'm really trying to change. A lack of recognition in from a healthcare perspective, that a normal test does not mean that a person is normal. A normal test just means that we don't know the answer yet, and somebody needs to be a detective to try and help this person find out what the answer is.
Yes.
So,
thank you for saying that.
This is a major problem, right? And if you think about the demand that healthcare professionals are experiencing, of course, there's different health systems, but no matter what, there's a demand. It is actually, unfortunately, easy to rely on that imaging test to say, we don't see anything, so therefore I can't do anything for you. And there's, 10-minute appointments, 15-minute appointments. It's really difficult to get into the nitty-gritty when the imaging is normal, because then what? What do you do, right? That my appointments are about an hour with patients, not 15 minutes. So we do get into that nitty-gritty. So the imaging has sucked for a really long time. Okay. It really has sucked for a long time, but it doesn't suck anymore. And imaging has the ability to visualize gynecologic diseases like never before. We can absolutely see endometriosis on ultrasound. We cannot see it in every single person. We cannot see every single nodule or every single deposit of the disease. But when we do see it, and we see it in a lot of patients, my endometriosis clinic, almost every Tuesday, we're diagnosing about 10 to 20 people with endometriosis, some that have had a previous, some that have never had a diagnosis, through imaging. And again, controversial, but the European Society of Human Reproduction and Embryology, ESHRE for short, they've been the first organization in the world to really very loudly declare that laparoscopy is no longer needed to diagnose endometriosis if you achieve a diagnosis through imaging. That has never been said before.
I need you to repeat that. I think that's so incredible.
I think it's incredible too. I know that there's a lot of people who are not happy with this statement because they think it's going to lead to more invalidation. But what it really represents is a transition in the mentality where the diagnosis can be made through imaging. That shouldn't be combined. So let me rephrase for a second. For a long time, diagnosis has been tied to treatment because there was this historic belief that the only way to diagnose endometriosis is laparoscopy, is surgery. And so if that diagnostic moment is tied to the treatment moment, the surgical treatment of the disease, the two have been melded so intrinsically that it's really hard now for people to separate these concepts from diagnosis and treatment simultaneous to diagnosis and treatment as separate entities. We can diagnose somebody with imaging and then discuss treatment options with them, which include medications, surgery, and what I consider the complementary and alternative management box. And we talk to patients about all those options, and then they get to decide what to do about it. But if you have historically combined surgery as the diagnostic and treatment tool, then surgery is the only treatment also at that point.
Right.
So what people are really afraid of is by taking out this concept of diagnostic laparoscopy as the diagnostic tool, we're also taking away surgery as a treatment tool. That's not true. There is no intention to remove the surgery as a treatment. It's just trying to separate the two so that way the diagnosis can be made earlier for somebody, and they also have the opportunity to make informed consent about their treatment options.
Right. And so is this the pushback that you're getting? Is that essentially you're speaking to the pushback that you're getting around this, that there's fear around the separation of the two?
Absolutely.
Yeah.
And I mean, I'm not representing that society. I'm not a member of ESHRE. I wasn't part of the guideline, but my, existence, my sort of philosophy is that when we diagnose patients with ultrasound in the clinic, we use that information to then plan the best treatment options, algorithm, whatever you want to call it, for that patient, working with them. And I can tell you, we're getting a little bit off the topic of diagnosis because it's so, again, intertwined with the treatment. But I have patients that we diagnose endometriosis in the clinic. We offer them all those options, and they actively want to not do surgery. So there,
of course.
And yeah. As a surgeon, I would like for my whole life to avoid surgery. I would never like to have surgery. So, and that's some people's belief. That's their desire, and they should be respected. The challenge with this pushback is the community of people who are trying to say, we shouldn't use imaging to diagnose endometriosis. We should only use laparoscopy. They're applying their beliefs to everyone. Mm. And that I don't think is, the right thing to do. We should all have a chance to live and breathe and be as we want. So for my patients in clinic, they get nuanced, individualized care, and they get to be in the driver's seat of that care. And by using imaging as a diagnostic test, you have a much better opportunity to give them that, because you can talk with them right after the imaging test. If you diagnose at surgery, there is no conversation. You are under a general anesthetic. You're not able to make an active decision about what do I do about my bowel endometriosis. If, for example, the urinary tract is involved with endometriosis in the form of a compression of the ureter, the tube that connects the bladder to the kidney, there's no opportunity in that moment, if the diagnosis is made at surgery, to have the urologist discuss the implications of that surgery with the patient. This type of advanced disease is actually the most appropriate disease to diagnose before surgery, because you need an opportunity to do further investigations, have further consultations, and truly plan for the treatments. And some people, of course, it's dependent on the nature of the disease as well as the severity. Some people may actively choose not to do surgery, and that should be respected as much as somebody who decides to do surgery.
Yeah, I think that this is such great information. And I keep thinking about those 4D ultrasounds for babies, and you see such amazing detail. So are you talking about an ultrasound that is seeing that kind of detail?
Oh, yeah. I can see I can see a 1 to 2 millimeter endometriosis deposit. I mean, you know, I don't want to really sound quite full of myself, but
No, please
I
do.
can,
It's amazing.
um, I can see superficial endometriosis, which even amongst the community of ultrasound experts around the world has been thought to be impossible. And with the research that I've done with my team in Australia, and I'm doing with my team now in Canada at McMaster University, we're pushing that envelope forward, being able to diagnose the most small endometriosis deposits. That's incredibly valuable information for the patient. In that moment, while they're awake, with me standing right there, telling them, hey, this is your endometriosis. And I turn the screen to patients and we point out the area of concern. In many cases, in that moment, we see tears. We see this like almost a complete relaxation of the body, because there is this instantaneous validation in the tangible, visible diagnosis of endometriosis on the screen, turning that screen to the patient. It's incredibly satisfying as a doctor for me to be that person for the patient, because they haven't had that before. And I think even if they're, you know, they get to, again, after that ultrasound, get to decide what treatments they want to do. The diagnosis itself has a therapeutic value. Simply telling somebody what's going on has a therapeutic value.
My mind is completely blown. I've obviously followed you for a little while now and seen that this is what you're doing. And of course, I've, always heard that laparoscopic surgery is the only true way. So this, as you've said, is just so revolutionary. And I have goosebumps because I just keep thinking about all the people who've come to me over the years, and the desperation is obviously so palpable, and really just wanting more options for people. And you're here providing them. And that is just incredible. And so I wanted to talk to you a little bit about how you go about, or at least maybe what you think needs to change in terms of the care model for endometriosis, because obviously in the US, it feels like a bit of a mess. And, there's really no clear path to diagnosis and treatment. So is it a matter of people being trained in ultrasound techniques and then being trained in like next steps for treatment?
There's about a million things that need to change.
Yeah.
It's,
Yes.
It's actually overwhelming how many gaps there are. One of the things that I really respect about some of the advocates is they've been educating patients about the importance of finding an endometriosis aware surgeon. So again, kind of going back to that concept of laparoscopy as a diagnosis and treatment, you want to make sure you have somebody looking after you that really understands the disease, because again, it is very enigmatic. You can be a gynecologist, do a laparoscopy, and completely miss the endometriosis. That's not a typical scenario, but it's possible. So there are advocates who have been pushing for years for the concept of the endometriosis excision specialist. And this is an incredible push. It's resulted in major changes in how gynecology looks at endometriosis surgery. The next step, in my opinion, is starting to advocate for endometriosis aware imaging specialists, because this is really going to be the game changer. We're going to start to see patients getting to the right surgeon based on the type of disease that is identified at the imaging. Whether it's ultrasound or MRI, to be honest, I don't personally really care that much. I think ultrasound is a cheaper tool. It's a smaller tool, so it can fit into the office of the gynecologist. MRIs, of course, are insanely huge. MRI demand is greater. So ultrasound has a lot of perks compared to MRI. But the bottom line is we need imaging experts who can be endometriosis aware, who are trained in diagnosing endometriosis and staging endometriosis, so that the patient can get, one, the diagnosis, and two, an understanding of the disease that they have, so that way they can get to the right person and make the right clinical decisions for themselves. That's going to be really difficult to achieve, because there are some jurisdictional issues around imaging, like sonographers perform the ultrasound in North America, and radiologists read the ultrasound, often not in the same space as the sonographer. They might be working from home, they might be working from a workstation in a different area of the hospital or the clinic. And endometriosis ultrasound is actually quite dynamic. You need to utilize your clinical knowledge of anatomy to move structures around, to see very subtle things. And so we have to train the sonographers to do that, which is a high level skill. And then we also have to train the radiologists on how to read the images that are captured by the sonographer. And I'm a gynecologist. I'm a gynecologist who does all of my own ultrasound and reads all of my own ultrasound. And so I'm not really in the world of radiology per se, but I'm trying to collaborate with that world because they're really the world that maintains the ownership of imaging in North America in particular. So one sort of very tangible thing that is actively happening in the United States and Canada is that there are working groups on endometriosis imaging. I'm part of the one in Canada, and it's a combination of radiologists and me as the gynecology lead to start to train sonographers, start to train radiologists. There's an equivalent group happening in the United States right now as well. So we're starting to see this. Again, very exciting time, but will people expect better imaging tomorrow or even next year? Maybe, depending on where you go. Seek out the people who have that training, who have that expertise. There are forums, there are, people have Instagram pages sharing what type of healthcare they're delivering. Try and find those people who are endometriosis aware, and that will help, push this forward a little bit more as well.
I feel like you're a unicorn. Oh my goodness. And I want there to be more unicorns like you. So what about getting, the most accurate information? Because I know you just talked about that, like getting to the right doctor, getting to the right practitioner. Where can people find the most accurate information about endo online? Because of course there's, like we said, there's still a lot of misinformation and confusion.
Tons. That misinformation comes from people in every domain. It comes from doctors, it comes from advocates, it comes from politicians. Like, people just don't fully grasp the very complex nature of the disease. So misinformation is rampant. And if you're part of the lay population, not, an endometriosis researcher or endometriosis clinician, it's really easy to actually not know how to distinguish. So looking for things like references on a website to see what types of articles are being referenced is one way to kind of judge the validity. There are people who simply make statements, and statements, are not necessarily going to be based on evidence. They may be based on a personal belief, right? So trying to understand, where is this information coming from, and using that knowledge to decide, is this trustworthy or not? Certainly there are websites that have started to collect, in some ways, databases on individuals who are endo aware, whether those are endometriosis surgeons or endometriosis imaging specialists. There's one in Australia that's called SAFE. I don't actually remember what it stands for. Sonographic or sonographer is probably the S. And it actually lists in every state in Australia which imaging centers are endo aware, which ones are doing endometriosis focused ultrasounds. I don't know if that exists yet in the North American sphere, in Canada and in the US, probably because there's not actually as much focus here yet as there is in Australia. But there are places that are doing it, and through Instagram and Twitter, you can start to get a sense of that based on their profiles, their endometriosis affiliated profiles.
Very helpful, and we'll share all of that in the show notes for sure. Is there anything else that you want to share with anyone who's listening about endo and diagnosis, or anything that you feel people should know?
There was one thing that came to mind as we've been talking that I think ties back to one of the earlier things around how endometriosis evolves, how it becomes a bigger beast than when it's in its infancy as a disease. Many patients with endometriosis have concurrent pain generating mechanisms. This means things that are causing pain at the same time as their endometriosis. So some of the common things would be adenomyosis, a condition of the uterus, very similar in mechanism to endometriosis. Patients with endometriosis often have hemorrhagic ovarian cysts. These are quite sudden painful cysts that form with ovulation, and they can be very shocking, very severely painful, sometimes requiring people to go to hospital. People with endometriosis can have concurrent bowel problems like IBS or colitis or Crohn's or celiac disease. And so the point of me saying all this is that concept of diagnosing endometriosis is much more than just diagnosing endometriosis. It's diagnosing what else is going on in this person, looking at the pelvis and looking at the person as a whole. Because if we are narrow-minded, only looking at endometriosis and we have blind spots to the adenomyosis or the hemorrhagic cyst, and we think, oh, we just need to treat the endometriosis and you're going to be better, or I'm going to be better after my surgery for endometriosis, that's misguided. And it will lead to disappointment. So having this clarity on the complexity of the pelvis, on the complexity of chronic pelvic pain generating mechanisms is so integral to good endometriosis care, because you actually have to kind of make a list of what's going on, and you have to individually check off, we are actually treating this problem. We are treating this problem. We are treating this problem. If the list starts with endometriosis and there's 5 items underneath, and you only have a treatment plan for endometriosis, good luck. You're not going to experience the outcome that you want, the outcome that you need, the outcome that you deserve. And so that's going to lead to disappointment. And so I really want to help people, and I do this all the time in my clinic, understand that endo is much more than endo. There's more going on, and we have to be holistic in our approach in order for us to reach success. That's my last message for people, I think, because there is, this insane focus on endo. It's a good focus on endo. It's changing things. It's revolutionizing the care, but we cannot just be narrow-minded focusing on endo alone, because it's not actually the way that we need to go.
Thank you for that. I know I've said so many times, it's not about your uterus. It's about so much more than that. And so thank you. That's very, very helpful. So where can people find you? Obviously you work in clinic. So are you taking new patients? What's your situation right now?
So I have my clinical practice at Hamilton Health Sciences and the McMaster University Medical Centre building. At this exact moment in time, my referrals are closed due to overwhelming demand and the inability to actually attend to people quick enough. Because again, there are not enough endometriosis focused doctors out there. But I will be reopening the referral soon. And so people can find a referral form on my website when it's launched, which is MathewLeonardi.com, Matthew with 1 T. And I'll also be making some announcements about the reopening on my Instagram account at Dr. Mathew Leonardi. I can also be found on Twitter. I can be found on YouTube, where I post some of my lectures. Often these lectures are to conference attendees, medical professionals. So they're definitely a little bit high level, but one thing I know about endo patients is endo patients are actually so smart, and they know a lot about their disease and their health. And so probably it's actually within their ability to understand. So you can check out my YouTube page for some educational videos as well.
Yes. Oh my gosh. Thank you. They're also so resourceful. So yes, thank you again so much, Mathew. This was really, I'm like I said, I'm so blown away by this information, and it has the power to change the world. So thank you for spearheading all of this.
Thanks for an opportunity to have a platform to share this information and get it out to the masses as much as possible. Because again, people are going to change things. It's not just me. Yeah, maybe I'm a little bit of a unicorn. I like that title. They're, pretty and cute too. So, but it's got to get out to the masses so that way we can make change altogether.
Absolutely agree. Thank you. That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at nicolejardim.com/quiz.